Good morning, my name's Nick Rumney. I'm an optometrist in Hereford and we're filming this in my practice at the moment. I'm going to talk to you about angle closure glaucoma for a number of different reasons. It'll become apparent as we go through the discussion. But first of all, what I'd like to do is acknowledge a colleague who's helped me with putting together some of this presentation, someone who teaches this subject at the University of Melbourne, Professor Algie Vingris. He's an optometrist with a special interest in clinical visual function and glaucoma in particular. What are my aims of the presentation? Well, what I'd like to set you back to is to think that angle closure glaucoma is taught to optometrists largely in the context of acute angle closure glaucoma. We hear about the patient arriving with the red eye. It's the classical differential diagnosis of the red eye that arrives in the optometrist's chair, usually in some pain. But this approach does risk missing some clinically relevant signs, perhaps not so much symptoms. We'll talk about that in a moment. And this presentation is just there to alert you to the prevalence of angle closure glaucoma, how much angle closure glaucoma there could potentially be in the community, and the lack of current guidance that perhaps mitigates against us picking it up when perhaps we might. So the presentation will begin with an introduction. We'll talk a little bit about the demographics of angle closure glaucoma, and that's quite an important issue for different reasons, but mostly to do with the aging of the population and also the changing of the racial dynamics of the population. We're going to talk a little bit about definitions of angle closure. We're going to look at some of the overviews and mechanisms of how angle closure occurs, and we're going to look at how it might be managed once you've identified it, once it goes on into hospital referral, hopefully. We're going to look at what you might do from a point of view of clinical workup to make sure that perhaps you do pick up the angle closure glaucoma that's sitting in your chair. And that's inevitably going to involve a look at the assessment of the angle. Hopefully we'll finish then with some guidance that might give you a little bit more interest in the subject and perhaps modify your practice a little bit. I'd like to introduce, first of all, a case that occurred in one of our GOC investigation committees. I've been sitting on the GOC now since 2001, and I've been an optometrist member of the investigation committee in all that time. We see a number of different cases, probably around about 170 referrals a year, of which only a few actually go on to be discussed at Fitness to Practice. And this is a case that came before us. So this involved a 54-year-old female South Indian lady. She was pretty much asymptomatic, some difficulties with her reading vision. She'd come along for a new examination. She had a distance prescription of right and left plus 250 with an ad. She returned with headaches after her new spectacles. Was it the new varifocals that she'd had? How did they differ to the previous ones? Didn't seem to be a huge difference, just the usual small increase in plus that we make our bread and butter from. Her IOPs were slightly higher at this stage on reassessment at 24 and 23, and they were repeated and found to be the same. However, the discs were normal and the visual fields were normal. So the optometrist phoned the previous optometrist because the patient had moved areas and asked whether these symptoms had been recorded previously. And they said, well, yes, this patient had these symptoms before, but there wasn't any more information recorded, and it seemed that an adjustment of the spectacles had perhaps sorted it out at that stage. This optometrist referred the patient in any case as he felt less confident about the pressures, and he noted that referral ought to be managed soon, as opposed to routine or as opposed to urgent or emergency. Well, therein lies a little bit of a tale because, of course, in most areas now, the hospital eye service no longer recognises soon. A referral is either urgent or it's routine. Now, this patient was sent an appointment for 16 weeks hence, but actually she was going to be away on holiday, and so she deferred that appointment to 22 weeks. And then just as she was perhaps about to go, there was another deferral, but this time from the hospital, pushing her out to 28 weeks. So it's nearly 6 months from when she was seen by the optometrist. Now, she actually attended A&E at week 24, with profound ocular pain in the right eye, blurred vision, and she was found to have an intraocular pressure of 48 millimeters on Goldman. Well, what do we have here? Well, we have a diagnosis of angle closure glaucoma, and it's acute angle closure glaucoma. It required immediate medication and iridotomy. She complained to the GOC on the grounds that the optometrist should have indicated more urgency in the referral, and that the optometrist should have warned her of what might happen that might precipitate her attending the hospital somewhat earlier. She did not complain on the grounds that she'd had to have treatment, because clearly she understood that she would have perhaps had to have that anyway. We determined in discussions within the investigation committee that there wasn't a case to answer. Now, this really tends to hinge on what is the current accepted standard of care, and it tends to hint at what other things did the optometrist do to mitigate the situation. The patient was, though, referred without an assessment of the anterior chamber angle, and there were some overt anterior chamber angle closure risk factors that were present. For example, her age, her race, the prescription, and also her symptoms. Now, the GOC Investigation Committee felt that the standard of care was just acceptable and the outcome had been satisfactory ultimately for the patient, and the patient did not lose vision. But could it have been better? The question we asked ourselves was, is there a learning outcome of some value in this? So in coming to a conclusion within the Investigation Committee, one of the first things we would look at is what guidance might exist out there. And we turn now to the college, where Section 18 of the college guidance on clinical guidelines discusses the examination of the patient at risk from primary open-angle glaucoma. They state in the guidelines that it's for the patient, for the practitioner rather, to satisfy themselves that procedures are included or excluded according to the patient's clinical need. But in addition to the guidance on the eye examination, good practice should normally include, when we talk about assessment of the optic nerve head, perhaps by dilation and bivolc lens, tonometry, where pressures are borderline or high, they should be repeated, and noting the time of day of the test, perhaps even repeated with a different technique, for example, applanation as opposed to non-contact. An examination might also include central visual field assessment with threshold control, and that might also need to be repeated. All a little bit problematical within the General Ophthalmic Services contract, but nevertheless, it's guidance as to what you might do. At no point in this is there any mention of a basic slit lamp assessment. There's a logical lacuna in the decision-making here, because you might ask yourself, well, how can you say that they are at risk or not at risk of primary open-angle glaucoma if you haven't looked at the OA, at the open angle? What if that angle was not open? You might have normal pressures, or they might vary at different times. The optic nerve head might look normal, it might look slightly curved. Unless you've determined whether the angle is open, you can't really say that there is an issue with primary open-angle glaucoma. So it leads me on to ask the question, well, what's the most common type of glaucoma? We're all familiar with our UK prevalence figures. Approximately 2% of the over 40s have glaucoma, and that risk rises by 50%, which sounds a lot, but actually increases from 2% to 3% if you have a parental family history. It does rise to 6% if you have a sibling family history, but actually it's greater than 8% if you're over the age of 75. So age remains a much more relevant risk factor for primary open-angle glaucoma. Well, let's have a look at angle closure glaucoma. Well, it's approximately 1% in the East Asian population, so this is Chinese, Vietnamese, etc. And it accounts for 50% of all glaucomas in India. So if you take a population study done in Vellore in South India, we find 43 per 1,000 people have angle closure glaucoma, but we only find 4 per 1,000 have primary open-angle glaucoma. And in terms of family history, well, we've just discussed that the risk with primary open-angle glaucoma rises from 2% to 3%. But in terms of risk with angle closure glaucoma, it's a little bit different because it is an anatomical variability. So approximately 6% of 50 siblings who had ACG also had narrow angles and anterior and angle closure glaucoma. 32% of those 50 siblings had occludable angles. So this is very, very much higher levels of prevalence amongst families. And in terms of occludable angles, we're looking at 6.4% in the Mongolian population, 2.2% in South Indian population. Whereas, as far as we're aware in Europe, about 7.5% of people have narrow angles, not all of which will occlude on dilation. So you might say that, in summary, given the populations of India and the populations of China, angle closure glaucoma could in fact be the most prevalent form of glaucoma in the world. So let's summarise these risk factors. In terms of race, Caucasian risk factors for angle closure glaucoma is 0.2%, and Asian risk factors 2 to 3%, a 10 times greater prevalence in the Asian community. In terms of sex, there is a 3 times change in terms of 3 times females to males. Age, it is more common in the elderly than the young, and you'll see why in a moment. And in hypermetropia, we're looking at about a 1.5 times greater risk. So perhaps we should just revise a little bit of our anatomy. And here's a classical scan from a textbook on anatomy of the eye. Very interesting picture because it shows the iris directly in contact with the lens, which we know is not or should not be normally the case. But you can identify the key structures, the iris, the canal of Schlemm, the trabecular meshwork, and the insertion of the ciliary body. And it's quite clear there why the angle might look in the way that it does when you look with the gonioscope. So let's think about whether there are different types of closure. Is it just one thing? Most of us grew up with the idea that perhaps we should be fearful of dilating our patients because their angles might close, and where would we be then? Well, we classify closure into 3 types. Primary, which is usually due to anatomical or mechanical effects. Secondary, which is usually due to some other syndrome, for example, pigment dispersion or exfoliation, or possibly as a secondary consequence of surgical or inflammatory episodes. And malignant, which might be related to neoplastic growth occurring within the angle or within the ciliary body. The rest of the presentation, we're really going to concentrate on the primary angle closure aspect. So what are the causes of primary angle closure? The most common of all is pupil block. Pupil block is where the pupil locks to a mid-peripheral, mid-dilated size and is very close in proximity to the central anterior surface of the lens. There is another anatomical variation called plateau iris, which we'll discuss in a moment, which is much more rare, but can occur and is quite an important issue. Now, in pupil block, we can see here in the diagram that the aqueous fluid is produced in the posterior chamber by the ciliary processes, flows through the pupil and out towards the canal of Schlemm. And it's flowing through that gap between the tip of the iris and the anterior lens. So we get lens growth and forward placement over the years, particularly in plus prescriptions, particularly in somebody who has development of nuclear sclerotic cataract, for example. They may get pupil touch. This is contact between the iris and the lens. That will elevate the intraocular pressure in the posterior chamber, which is actually a normal phenomenon. It does occur. And then a combination of muscle vector forces that will result in both iris hypoxia and some inflammation tends to close up the angle, and the pupil blocks in position, so the iris can no longer dilate or constrict. This compromises the aqueous outflow, so it pushes the iris forward, which is the iris bombée, so-called iris bombée. And here we show a picture of a larger, more forward lens, and you can see that it's pushed the iris forward and it's occluded that angle. The pressure is coming in from the rear of the posterior chamber, which is forcing, by the muscle vector forces, forcing the tip of the iris and the edge of the pupil down against the lens. Note also that the anterior chamber is comparatively shallow compared to the other picture. So, what's the most important feature for primary open-angle glaucoma? Well, we'll come on to that in a moment. But what about the evidence? Is there any evidence that this pupil touch and block actually occurs? Well, Quigley, who's a doyen of glaucoma researchers, has identified this using shine fluid photography, and this demonstrates here that there is a rise in the posterior chamber pressure associated with a reduction in pupil diameter. So yes, the posterior chamber pressure does increase as the pupil starts to decrease in size. And here we can see pupil contact with the anterior lens and the effect of pressure bulging the iris forward. So some summary mechanisms here. Pupil block is due often to a large lens and to touch, hence the relevance of a plus or hypermetropic prescription. And the relevance of our patients that we see year on year who may have little or no signs of glaucoma perhaps at one visit, but their prescription might rise plus 150, plus 2, plus 250, plus 4, etc., as time goes by. So things can change in this situation. There are misdirected vector forces that push the pupil and the iris into the angle. And forward lens movement, well, you could arise as a result of a malignant form of glaucoma. It could be arising as a result of choroidal swelling or even the aqueous misdirected. Ultimately, we get a low-grade iris ischemia where the radial arteries of the minor arterial circle get constricted. You get an inflammatory sort of response. The tissues are somewhat sticky, which doesn't help when you're looking at the pupil touching the surface of the lens, and then posterior synechiae up at the angle, also exacerbating the block effect. Ultimately, you get peripheral iris atrophy and the loss of the rough of the iris just around the pupil margin. And so the end stage of pupil block is posterior synechiae, contact with the pupil against the anterior surface of the lens, the iris bombé, where the iris is bulging forward, and a stagnant aqueous resulting in iris corneal damage and limbal flush, the so-called red eye. Now, plateau iris is a very rare anatomical difference that results in angle closure. It's caused by the anterior insertion of the iris or ciliary body onto the ciliary body is much closer to the canal of Schlemm. This allows the iris to be very close to the trabecula, and so dilation actually gives the iris bunching appearance inside the angle, and this is a physical compromise to the drainage. So here we see a normal insertion with a normal iris and ciliary body, and as the pupil dilates back, enough space is left to maintain drainage. Here we see in plateau iris the iris insertion is much closer to the trabecular meshwork, and here when the dilation occurs it blocks it off, resulting in a rise in pressure. And it is this relatively rare anatomical variation that results in the wives' tale of the increase in intraocular pressure arising as a result of dilation, which has in some respects held us back over a number of years. Now, what are the results of aqueous stagnation? Well, a phenomenon that can occur is something called lens Glockenflecken, which are little white specks or flecks like little ash particles over the central affected zone of the lens, results in iris ischemia, the compression of the arterial circle, and corneal endothelial compromise and corneal edema. Ultimately breaks in decimase. This time you would expect it to be extremely painful to the patient. Stage 1, you get basal cell swelling, vacuole formation. Stage 2 and stage 3, the vacuoles coalesce, and the cornea is now so-called quite steamy in appearance. Now, we have to be careful in all of our red eye differential diagnosis, in particular with primary open-angle glaucoma, it's differentiating it with uveitis. Classically, you have angle closure glaucoma giving you a fixed dilated pupil with high intraocular pressure, and uveitis giving you a myotic pupil or sometimes misshapen pupil with a low intraocular pressure. This isn't always so, and anterior uveitis will occasionally show a high IOP, and also there is a particular phenomenon or syndrome, Posner-Schlossner syndrome, sometimes known as glaucomatous-cyclic crisis, where the two things seem to run together, and that's treated as an inflammatory condition. Now we might move on to classify our primary angle closure glaucoma into two forms: acute, where you have a total angle shutdown, usually secondary to the other cause, or long-term angle compromise with very high intraocular pressure. Occasionally, but not always, will it be preceded by prodromal symptoms or signs, so it can come pretty much out of the blue. This is an ocular emergency and requires immediate referral. So this is your true ocular emergency, along with the cataract from out of town with cash. Moving on to creeping angle closure glaucoma, this is somewhat more common and begins usually superiorly, moving nasally, and it's a gradual 360 degrees zipping up of the angle, usually occurring over a period of months or even years. This is what you might deem to be an emergency waiting to happen, because it's clearly going to gradually change the dynamics of aqueous outflow, and ultimately a point will be reached where the pressure will just keep rising. Now, there are symptoms associated with primary angle closure glaucoma, and many of us are aware of these. Vision might be blurred at night, often worse at mid-dilation. There may be halos around lights associated with the corneal edema, and there may be headaches and ocular pain, often relieved by sleep. And it is quite important to bear in mind that these are very optometric symptoms. Blurred vision, perhaps halos around lights less so, but certainly headaches may often be associated with an incorrect refraction, for example. There may be vomiting, and in some occasions when the patient is unable to communicate particularly well, might even be confused for stomach or tummy upsets, and even the classic case of the possible appendicitis that was just really, in fact, an acute angle closure glaucoma pain. Moving on to discuss creeping angle closure glaucoma, that's symptom-free in 77% of cases. So there will not be any headaches or ocular discomfort. It's not a common symptom. IOP might rise at times, but not necessarily post-dilation. There may be progressive disc damage, and there may be visual field loss. And of course it may happen more so in one eye than the other. But you'd expect the iris to be active, the cornea to look okay. Clearly what we're in a situation here is of something that may well mimic primary open angle glaucoma. However, in this particular circumstance, the angle is narrow, both on Van Herrick and on gonioscopic examination. So in this situation, with a partly closed angle, you would be looking at referring the patient in. You may be able to do gonioscopy and look for pigmentation in the trabecula. There may be these symptoms of headaches or halos, etc. Something like 30% of angles with no visible structures. So this would be over 4 clock hours. So around about a quarter of the circumference of the iris. If that's closed, they will progress to angle closure glaucoma within 5 years. 75% of angle closure glaucoma cases have an anterior chamber depth of less than 1.6 millimeters. And of course, if you're finding this in one eye, the fellow eye will similarly be at risk. And it comes down to really the most important features of the anatomy that are going to be relevant. Now, we've discussed that the diagnosis of primary open angle glaucoma would be unreliable, except in terms of symptoms, except for an acute attack. There's little or no pain if the IOP rises gradually. A previous history of attacks or of a family history is certainly of relevance. And I certainly make a point of, when I talk to a patient who attends who's saying, I have a family history of glaucoma, well, I ask them what sort of glaucoma. And of course, patients might not know precise diagnoses, but they know whether somebody had surgery, whether somebody was in pain, or whether somebody was treated with drops, and that's usually a good indication. So certainly a family history of angle closure is of more relevance. The signs, well, you'd be looking for pressures of over 22. Caveat on that, of course, is we're all a little bit cautious about our pressures these days in the context of pachymetry measurements. Also looking at the optic nerve and the fields. So far, we're really looking at a symptomatology and signs that are very similar to primary open angle glaucoma, except that the anterior chamber is shallow. So you might go on to screen that with perhaps the shadow test or Van Herrick's estimate. You might want to look at the pigmentation around the ruff of the iris, or also into the trabecular meshwork. And you may want to measure the anterior chamber depth, and there's different ways of doing that. But ultimately, the gold standard of diagnosing angle closure glaucoma is to use the gonioscope. So the importance of the anterior chamber depth, 75%, so 3/4 of angle closure glaucoma cases have an anterior chamber depth of less than 1.6 millimeters. Typical average anterior chamber depth is between 2.5 and 3 millimeters. So here again we see the relevance of the hypermetropic eye, the small eye, and also the developing nucleosclerotic cataract and the swelling lens. Now, in terms of screening anterior chamber depth, a very, very simple technique to use is the shadow test, where you just use a pen torch shining in from the side. And on the left-hand picture, we can see that as you shine the pen torch in from the right, the dark area is in shadow, but the whole of the front of the iris is illuminated. On the right-hand side, when you can see that the light is being shone again from the left into the angle, you see a much greater area is being held in shadow. This is a relatively simple test, and much, much simpler to perform with the naked eye, and certainly simpler than the Van Herrick test. It estimates the anterior chamber depth from the bowing of the iris. You would fail with more than 50% of the iris being in shadow. Now, it's also quite interesting because if you get an iris that has a reverse bow to it, or a hollow or a different sort of shape, it can actually detect that. And here we can see a picture that actually shows a dark area, a light area, and a dark area concentrically, so that it's possible to actually get an idea of the anatomy from that relief lighting obliquely across the surface of the iris. In terms of screening for pupil block, it's quite a good combination of sensitivity and specificity. So basically, if you have a pass test in shadow test and a pass test in Van Herrick, then you have a 98% chance of the angle not opening. But obviously, if you fail either of those, then it's much more significant. A method for measuring the anterior chamber depth has been demonstrated by ophthalmologist Redmond Smith, published in the British Journal of Ophthalmology back in 1979. And this uses the reflections of a horizontal slit beam held at an angle to the eye. You basically observe the corneal reflex and you look at the lens reflex, and you measure the length of the beam so that the two reflexes just touch. That measurement is calibrated on the slit lamp. You multiply it by 1.4, and so you get an average anterior chamber depth in the population of 3.14, and so less than 2 is certainly going to give us cause for concern. We're going to be making a measurement now looking at the depth of the front chamber of the eye. I'm going to use this microscope. So we swing this around in front of you. Actually, I'd like you to pop your glasses off if you could. Thank you. Pop your chin just onto the rest there. Forehead towards the bar. Is that quite comfortable? Mm-hmm. Just bring you up a little bit, drop that down a touch. There we go. So, what we do here is we obviously have the slit lamp turned on. We have it set to the brightest beam, and we're onto the section of the slit lamp where you can adjust the height of the beam. Now, what we need to do is to first of all establish a 2 millimeter wide beam. So when we're in focus, the beam will be 2 millimeters measured on the scale at the bottom of the illumination system. We then turn the slit to be horizontal. So we have a 2 millimeter horizontal slit, and what we then do is set the arm to be 60 degrees to the observation system. We then move in to look at the surface of the eye, and what we will see is a reflection of light off, first of all, the cornea, and secondly, the anterior surface of the lens. And we adjust the height until the two lights meet, and then we take a reading from the scale at the top here, which comes in at something like 1.6. We multiply that by 1.4, and that gives us a depth in millimeters of the anterior chamber. Once you've identified a patient and you've referred them, the game in the management of this condition is to get the IP down as fast as possible. That might be under a number of different methods. For example, surgical. They might actually put a needle into the anterior chamber. It might be medical, using hyperosmotic agents, or they might seek to reduce the aqueous flow by carbonic anhydrase inhibitors, perhaps IV or oral or topical, and then also beta blockers and alpha agonists might be used. You want to re-establish the aqueous flow, and if there is inflammation, to control that, probably with steroids. And this is all taking place in the hospital, and it's an A&E ophthalmology responsibility. It is an ocular emergency. It does require immediate treatment because you never know how long that's been raised. So you should result in all cases being treated in this way, bearing in mind that 48 hours of optic nerve ischemia will lead to total loss of vision, so you have to be moving quickly. The loss of vision is avoided ultimately by bilateral surgery. So once the pressure is reduced down to a manageable proportion, then surgery would be indicated. Now, of course, we have heard of cases, and many optometrists have experienced cases where pupil block has been induced by the optometrist. Sometimes as the pupil constricts back down after dilation, this may occur, or it may be the so-called plateau iris that we discussed previously. Well, in fact, it's sufficient just to reduce the block if it's only just occurred. If there's no ischemia yet evident, then you'll still be able to move the iris. This is a problem now for optometrists because, of course, pilocarpine is no longer available to optometrists as registered. You have to be at the AS level of therapeutic grading before you can get access to pilocarpine. So it does mean a call to the ophthalmic A&E department for them to initiate immediate medical treatment, bring the pressure down with pilo, and then use a peripheral laser iridotomy. This doesn't necessarily need big guns of immediate surgery, and this would be the chosen management for the creeping angle closure form, and then they would be into the hospital on regular monitoring at outpatients before they decided whether further intervention was necessary. Ultimately, with pupil block, the iridotomy, well, it has to be bilateral because if it's happened in one eye, it sure as hell might happen in the other. The success is dependent on the iris contact and the anatomy. So some of these little holes will self-seal over a period of time. Iridectomy is another form of bilateral surgery, usually superiorly, so that the iridectomy pupil doesn't interfere with vision. It's perhaps more versatile with different iris anatomies. Some have better outcomes than others. Lens extraction, of course, if the patient does have a cataract, then lens extraction makes a lot more space and a lot more depth in the anterior chamber, and that's a very successful method of management, but it may require drugs as well as surgery. Screening for family members would also be recommended. So when are we going to actually examine the angle, and how are we going to go about doing it? Well, the sort of situations where you'd want to examine the angle is, in my opinion, any glaucoma patient or any patient with a glaucoma risk factor. So if you've identified someone you think there's a possibility of having primary open-angle glaucoma, I think it behoves you to assess whether or not that angle is narrow. And if they have other risk factors, such as age, a more elderly person, a female, particularly perhaps from the Asian or Chinese community, then these are particularly important indications for examining the angle prior to making that referral. Long-standing diabetic eye disease, because of course you might suspect neovascularization into the angle. Aphakia, again, earlier forms of surgery that didn't involve implants may affect the insertion of the iris and ciliary body. Any contusion to the eyeball or orbit, including long-standing injury, and here we move into the area of something called angle recession glaucoma, where even 30 years after an injury like a shuttlecock or a squash ball into the eye can actually cause the ciliary body to fall away from the trabecular meshwork, and the end result is a sudden rise in pressure many years later. So somebody with a contusion history needs to be examined regularly in terms of their anterior chamber, and always with a view to this secondary glaucoma. Old central retinal vein occlusions, suspect neoplasms, developmental abnormalities, and a number of other things that might indicate it's worth looking at the angle. There are, of course, other syndromes, for example, pigment dispersion syndrome, where we typically see the Krukenberg spindle, the dusting of pigment on the corneal endothelium. A giveaway sign here as well is that you'll start to see iris transillumination. So again, looking with the slit lamp, you start to see the sheen of the red reflex coming out through the iris. These patients often have a deep anterior chamber, and the iris periphery is somewhat lax and bowed because it doesn't have the pigmentation layer in support. The standard of care really would be to check the pressure, the fields and discs annually, and including counselling about the patient or with the patient about what the consequence ultimately might be. Ultimately referral when the IOP begins to show signs of rising. Another syndrome often overlooked and that will be missed again without slit lamp examination is the exfoliating lens capsule. This is generally easier done on dilation because you can actually see a ring in the capsule, and the top left-hand photograph shows this, where the central part of the capsule of the lens has actually exfoliated away. You can sometimes get a view of that with a glancing narrow slit lamp beam, but really, if you're suspecting it, you really ought to be dilating. You get an appearance something like dandruff or sort of flaking around the collarette of the pupil. And this is much more common in Northern Europeans, tend to be Scandinavian descent perhaps. And management again would be monitoring it and observing it, checking the pressures at regular intervals. Moving on to our assessment, we've discussed how a simple pen torch test, the shadow test, can help. Van Herrick, most optometrists are familiar with this, but as a revision, it's basically comparing the anterior chamber depth between the endothelium and the iris at the limbus, and comparing that to the corneal thickness in the slit lamp optic section. This is graded into 4, where you might say that grade 4 is where the anterior chamber depth is equal to that of the cornea, grade 3 where the anterior chamber depth is between 1/4 and 1/2 of that of the cornea, grade 2 where the anterior chamber depth is 1/4 of the cornea, and grade 1 where the anterior chamber depth is less than 1/4 of the cornea. And here we see a Van Herrick angle. The black space is what you need to look for and decide on how thick that is in relation to the corneal reflex. Grade 0, overleaf, where it's less than 1/4, you might say that that angle is closed. Grade 1, closure is probable. Grade 2, closure is possible. And grade 3 to 4 is wide open and incapable of closure. Grades 0, 1, 2 and 3 occupy about 6 to 7.5% of the population that you'll see in practice. So that's reasonably common enough that it's worth having a look. And of course, if you have a look with a slit lamp, you've got to pick up lots of other things as well. But ultimately, the gold standard for any assessment of the anterior chamber angle and for angle closure glaucoma is that of gonioscopy. Gonioscopy is a technique that strikes fear into the hearts of many optometrists. It's not something that's been commonly taught, and certainly the situation that's arisen with the post-variant CJD attitudes towards contact lens examination of the eye has led to a downplaying of this technique within the university sector. Arguably, it's a potentially very important technique, and it's no more frightening than any other technique that we do in the practice. There are some contraindications for gonioscopy. For example, if the patient had recently suffered acute trauma, you wouldn't be doing it then. You wouldn't do it immediately post-surgery. For example, if they'd had something like LASIK, and why would you anyway? A patient with high femur resulting from a contusion injury, you wouldn't indicate for gonioscopy at that point. But as mentioned earlier, because of the long-term risk of angle recession glaucoma, I think you probably would want to ultimately bring the patient back when everything's settled down. And again, this is where the crossover management between ophthalmology and optometry begins to occur. If you've got any suspicions of perforation, that would not be a good indication for examining with the gonioscope. There are two basic methods of gonioscopy. Of course, as revision, it's because of total internal reflection that means the angle is not visible directly from the anterior eye via the slit lamp. So you actually have to look into the angle obliquely. That can either be done with a plus lens, which is called the direct method, a Kirpi lens, which tends to be more reserved for surgical interventions because it's more of a direct view, a bit like a direct ophthalmoscope. If you move left, you're looking left. Whereas with the indirect method, you're actually looking at a reflected view. So when you look at the inferior mirror, you're actually looking at the superior angle. Two different designs of that. You might have a single mirror lens, which you have to rotate into the different quadrants. I find it most easy with a 4-mirror lens, which means you really only have 4 quadrants to look at. Moving on to the anatomy of the angle as visualized in gonioscopy. As we move from the cornea down and looking to the left-hand side of this picture, you see Schwalbe's line, which is a faint brown line, sometimes more heavily pigmented than others, in which case it's known as a Sampiolese line, and that's the indication of the furthest extent of the cornea. That signifies then moving on into the trabecular meshwork, which may be anterior and then posterior. Then there's a white pale line, which is the scleral spur, where the sclera comes in behind the ciliary body. You then have the dark brown of the ciliary body and ultimately the iris root. And as we look at that diagram, we can see with the angle closing up as we go around to the right, each of the various structures, like a series of layers in a cake, get alternatively occluded one after the other until ultimately the angle is closed. So what's in the angle? Well, when you're actually looking at it through the gonioscope, you see a corneal focal line, which is like your typical slit section that's seen in all slit lamp examination, and that seems to come to a stop just at the point where Schwalbe's line occurs, and it then travels across the trabecular meshwork, over the ciliary body processes and onto the iris. So we're looking for that series of lines just changing direction subtly. And if you have an occluded angle, then what will happen is that the two lines from the slit lamp will actually meet. So that of the cornea and that of the line over the iris actually meet. Whereas if you have an open angle, there is like a deflection on the line. And you can see that on the right-hand picture here. So it becomes much more obvious that it's actually dipping into an open angle and coming out again. A little bit like the idea of a bayoneted blood vessel in an optic nerve. If you can actually see the closure there, if you see the two lines meeting, then we're looking at a closed angle. Now, how do you go about recording this? Of course, it would be nice if we could photograph these things. They are quite difficult to do. I find the simplest thing of all to do, and pick this up from some American colleagues, you basically draw a circle which gives you the clock dial looking at the front of the eye, and you divide it into 4 quadrants, top, bottom, left and right. And then what you do is you write down what is the most posterior structure that you can see in each of the 4 quadrants. So you might write down TM, which is trabecular meshwork, Schwalbe's line might be SL, and TM might be trabecular meshwork. So here we have an angle that's open. It's open significantly from the 11 o'clock right through to 4 o'clock because Schwalbe's line is visible, but it's closed or closed more narrow in the area from 4 o'clock round to maybe 11 o'clock. And basically, if you record that, you can identify whether the angle is at risk of closure or not. This table shows Spaeth's grading of the positions and relevance of the structures that you can see. Essentially, if you can see any of the trabecular meshwork or backwards, then you're going to be looking at basically a normal and open angle. But as you start to miss being able to see the trabecular meshwork and the angle starts to occlude up to the point where Schwalbe's line becomes invisible, we're looking at a pathological situation, an angle that's heading for closure. Now here's an example of a gonioscopy view showing some pigment in the trabecular meshwork, and there's also some zonules that's showing some exfoliation material there. On this particular picture, you can see to the left-hand side, you see the trabecular meshwork, the white of the scleral spur, and there's a very dark area like a cavernous valley that's hidden just in at the iris root. And this is the angle recession. It's subsequent to trauma, and it does confer a lifetime risk of secondary glaucoma. So just be aware of somebody that has had a blow to the eye, probably needs this looked at, and certainly needs their pressure checking at regular intervals thereafter. So in order to undertake a gonioscope examination, what we need to do is take a gonioscope lens which has been previously soaked in hypochlorite. I prefer to just give it a final wipe over with an alcohol wipe, just swab it, and obviously we don't want that directly in contact with the eye, so we'll take some tissues and we'll just rinse that off with some saline, dabbing that dry. This is a 4-mirror gonio lens. You can see the 4 angled surfaces like a pyramid, and it's also an aspheric contact surface so that it matches the shape of the cornea. I'm going to take some contact fluid. I prefer to use Celluvisc because it's sufficiently viscous. I tend to find wetting agents are just a little bit too liquid. Just make sure that we're getting the flow of fluid to the end, and then in one continuous flow pour it in, not too much, but the whole idea is to have no bubbles present at all. And that's it, ready for application to the eye. So here we are, set up with the patient anaesthetised at 1 drop of 0.5% proximeticaine. We just position ourselves so we're very close to the eye and the lens is nearly in position. I then move to the side. I get the patient to look down. I just gently rest the edge of the lens just on the lid, and then I ask the patient to just gently look forward, and we have a lens in position with no air bubbles, and we rotate until we get our mirrors into the correct position. I then prefer to go straight to the vertical meridian. And the one trick I've found is that actually a little bit more magnification than you might expect will give you a better view. And I can see Schwalbe's line, the anterior trabecular meshwork. There are 1 or 2 little iris processes just around to the side. We scan then down to the lower part of the gonio lens. And what you may find is that you now have to lower it down very slightly to get into the view of the angle. Once again, trabecular meshwork clearly visible. And then we move back up to the centre, and at this point, if we're looking to the side, we'll rotate to a horizontal beam and move in first of all to the temporal mirror, which actually gives us, of course, a view to the nasal side, and then across to the nasal mirror, rotating the lens again, which gives us a view to the temporal side, which is actually slightly more narrowed, and at around about the 2 o'clock in this view we have just the faintest whisker of trabecular meshwork visible, but all the way round the rest of it perfectly visible. Now we move the slit lamp away to remove the lens, and then just apply gentle pressure to the edge of the eye and it flips out like so. So we may end up with a practical classification that would be very useful to think of in terms of what we do in everyday practice, because of course most of our patients don't turn up with particular problems. In terms of angle closure glaucoma, you could have a classification of subacute or angle closure suspect or prodromal. This would be a patient who had normal intraocular pressure. They might have a closable angle, and they may not have disc or field changes at this stage. A next step might be where you had angle closure hypertension. So this is where you had a high intraocular pressure with a closed or a closable angle, again without disc or field changes. Chronic angle closure glaucoma, and I'll repeat that because it doesn't run off the tongue quite as simply as conventional primary open angle glaucoma, but chronic angle closure glaucoma is where there's a high sustained intraocular pressure, a closed angle, and with disc and field changes. Now, this subgroup is the creeping angle closure glaucoma, and this is where the angle is zipping up around and increasing in pressure as time goes by and doing damage. And in the case of the discussion right at the beginning of this presentation, this is the one that could be mistaken for primary open angle glaucoma. In acute angle closure glaucoma, there's a high intraocular pressure, a closed angle, but now we've got the ocular pain, the redness, and the reduced vision. And I would contend that this group is actually relatively rare in practice, and putting it into context, I think in 25 years I've seen 4, whereas in the past 2 years I've seen 4 chronic angle closure glaucomas. So perhaps that gives some indication of the concern at missing the importance and the relevance of angle closure. An alternative classification on this table shows the possibility of symptoms that may or may not arise, moving from the possible to the acute pain. So in conclusion, I think you can only make a diagnosis of primary open angle glaucoma if the angle is proved to be open. And I'm quite happy to accept that a Van Herrick technique, a shadow technique, something simple based on a slit lamp that's familiar and comfortable with most optometrists is certainly one way of doing that. But I would not be comfortable at referring open angle glaucoma suspects without determining that. I actually don't think that you should pass an opinion on an anterior segment without a slit lamp examination, because there are so many different things that you can pick up and see that might be going on. And even if you can't do gonioscopy, you can look at the angle with the Van Herrick technique. You can use the simple pen torch shadow technique. And an adaptation of the Van Herrick technique is something I would often use out in domiciliary visits. Just use the streak of the slit lamp, focused up and held a little bit further away from the patient. So you just get a focused beam and cast it over the anterior chamber. It'll tell you whether you're dealing with a deep or a shallow anterior chamber. And if you doubt me, perhaps the next time you see a patient who's had a unilateral intraocular lens implant, just look at the depth difference in the anterior chamber, because one eye will show quite a deep anterior chamber and the other eye will show quite a narrow anterior chamber. And it becomes much more obvious if you can test yourself and practice on somebody with an obvious difference. But in the end, diagnosis of any of the glaucomas, it really isn't possible without gonioscopy, and any glaucoma scheme that is using optometrists as a primary filtration device really needs to be looking at the possibility of determining whether or not there is a closed angle at that point. I would contend that angle closure glaucoma is significantly underdiagnosed, and I think it's not only underdiagnosed in optometric practice, I think it's also sometimes underdiagnosed in the hospital sector. Gonioscopy is a perfectly feasible primary care procedure, and it should be integral to any primary care glaucoma co-management scheme. So in conclusion, my opinion is that our guidance that we're given at the moment isn't really adequate in that it overly concentrates on primary open angle glaucoma. Probably for good reason, because primary open angle glaucoma is something that optometrists historically were felt to somewhat over-refer on. Also because it's symptom-free. It's important to maintain that battery of tests that are most likely to detect it. But of course what we've seen this afternoon is that the presence of angle closure glaucoma does not necessarily come along with the symptoms that we've all grown up to expect and anticipate. And there are many symptom-free situations where angle closure glaucoma ought to be suspected. And I think my final point would be, in a multiracial society where we know, for example, that Afro-Caribbean communities are much more prone to open angle glaucoma, it behoves us to understand that the Asian and Chinese communities are particularly prone to angle closure glaucoma, and that ought not be overlooked.